Assalamualaikum and good morning everyone. Thank you Dr. Rafeek, Dr. Fairuz and my fellow colleague lah. So today I would like to sharing about thyroid storm, okay, which is uncommon to see in ED nowadays. I'm personally still not involved in treating thyroid storm lah.
So kena duduk lama lagi kat ED lah sampai jumpa thyroid storm baru boleh keluar lah. Is that what you're saying?
I hope can see first but able to handle lah. Okay, so for introduction, so I will cover definition, the risk factor, basic anatomy, diagnosis, symptom and sign, and also the blood investigation, also the management lah. So thyroid storm is actually exacerbation of the hyperthyroidism lah. It's an acute and life-threatening hypermetabolic state. So thyroid storm is a rare disorder characterized by multi-system disorder which mortality rate will ranging about 11 to 25% lah. So thyroid storm mainly result from the triggering event in conjunction with underlying hyperthyroid condition lah. So for terminology, hyperthyroidism is meaning of overproduction of hormone from the thyroid gland. Thyrotoxicosis is any cause of excessive thyroid hormone concentration. Graves' disease is an autoimmune disease which characterized by metabolic imbalance resulting from overproduction of thyroid hormone. And then for the end is euthyroidism lah. For is a normal function of thyroid gland which have a normal serum level thyroid hormone. Okay. The major precipitant for thyroid storm is first for non-compliance to anti-thyroid drugs lah. So patient which diagnosed to be thyroid storm actually has underlying thyroid lah, mainly lah previously. So the other condition which made him to be in thyroid storm is second one is discontinuation of anti-thyroid drug. Personally, he stopped lah. So other than that, which may precipitate is when their body in stress condition, such as severe infection, cardiac event, in thyroidal or non-thyroidal surgery, in trauma, or in administration of iodinated contrast and radioactive iodine, also in pregnancy and delivery, in adrenal insufficiency, and also DKA lah, diabetic ketoacidosis. Okay, so we go to the basic anatomy of the thyroid gland. So thyroid gland is located in the neck below the larynx.
Hopefully semua dah tahulah thyroid ada kat neck Ini saja je, Syahmi saja je ni. Kod tak ada orang confused lah thyroid ada kat mana.
Which made up of two cell lah, type of cell. So the first cell is a follicular, the second cell is parafollicular. So the follicular secrete the hormone T4 and T3, and the parafollicular secrete calcitonin lah, which both T4, T3 and also calcitonin involved in multiple organ function and system. So we go to the symptom and sign, we can define and we can see lah how their effect if in thyroid storm lah. Okay, so this is picture shows thyroid gland lah. We have right and left loop, in between is isthmus lah. So in the back view we can see 4 parathyroid gland. Okay, so thyroid system actually the central nervous system control is hypothalamus lah, which secrete thyrotropin releasing hormone TRH, and then stimulate the anti-pituitary gland, which secrete thyroid stimulating hormone TSH, and stimulate thyroid gland to secrete T3 and T4 and also calcitonin lah. Okay. So the etiology and the causes of the thyroid storm, the most common one is grave disease lah, which is autoimmune disease lah. And then the solitary toxic adenoma and also toxic multinodular goiter lah. So other rare causes that cause thyroid storm: hypersecretory thyroid carcinoma, thyrotropin secreting pituitary adenoma, stroma ovari teratoma, human chronic gonadotropia secreting hydathiform mole. Other causes interferon alpha, interleukin 2 induced thyrotoxicosis lah. Okay, so to diagnose thyroid storm, basically we use two scoring lah. Birch-Watowski point scale, BWPS, and the second one is Neuro Japan Thyroid Association, GTA scoring. So for the BWPS, is used for quantitatively score. Dia count by number, kita bagi score. So based on thermoregulatory, tachycardia, atrial fibrillation, congestive heart failure, CNS, gastrointestinal and hepatic, and the present of the precipitating event lah. So we can see after this the table. So to score more than 45 is indicate thyroid storm, 25 to 44 indicate impending thyroid storm lah. GTA or Japan Thyroid Association scoring is a qualitative lah. So they categorize into TS1 thyroid storm 1 or TS2 thyroid storm 2, which the present of thyrotoxicosis as prerequisite lah. Okay, so we see the table. Okay, so we have thermoregulatory dysfunction. Temperature recorded, we give scoring 5, 10, 15, 20, 25 lah, according to this table lah. And then VS cardiovascular dysfunction, tachycardia, also 5, 10, 15 and 20 according to this table. And then the CNS effect, if no effect, 0, mild, which feeling agitative, so we give 10. Moderate, 20, feeling delirium, psychosis or extreme lethargy, or severe, patient come with seizure or coma, we give 30. Congestive heart failure, absent is 0. Mild is 5, ada pedal edema. Moderate is 10, we hurt by basilar rails. Severe is pulmonary edema, we give 15. We do ECG, if no AF, 0. Present of AF, we give 10. Gastrointestinal or hepatic dysfunction, absent is 0. Moderate is 10, which means diarrhea, nausea, vomiting, abdominal pain. Severe is unexplained. Okay, so precipitating history, either thyrotoxicosis or not previously, ada adenoma sebelum ni, ada cancer sebelum ni, so is positive, we give 10. So these are actually the function of T3 and T4, also calcitonin lah. Okay, so for the table Japan Thyroid Association GTA, which qualitative, so prerequisite for diagnosis is present of thyrotoxicosis, which the T3 and T4 is elevated. So the symptom, so we look first for diagnosis. We have TS1 and first combination, and also TS1 alternate combination, TS2 first combination, and TS2 alternate combination. So to diagnose TS1 first combination, either thyrotoxicosis, at least one CNS manifestation, and fever, tachycardia, ada congestive heart failure, or GI hepatic manifestation. TS1 alternate combination, thyrotoxicosis, and at least 3 combination, fever, tachycardia, congestive heart failure or GI hepatic manifestation. Kalau TS2 first combination, thyrotoxicosis and a combination of 2 of the following, fever, tachycardia, CHF or hepatic GI manifestation lah. TS2 alternate combination, patient who met the diagnosis TS1 except serum T3 and T4 are not available. So actually the GTA, they are waiting for value of T3 and T4 first, and then combine with the symptom and the sign lah. Okay. So these are sign and symptom of thyrotoxicosis. Involved in many organ lah. So for first organ, we can see in the patient may come with emotional lability, anxiety, confusion, coma, and the sign we see muscle wasting, hyperreflexia, fine tremor. Lepas tu sometimes with paralytic paralysis. For GI system, will come with diarrhea, hyperdefecation. For reproductive system, complaining of oligomenorrhea for many years, or gynecomastia, and then decreased libido. For the skin, you can see the spider angioma atau spider nevi. So the thyroid gland, we can palpate, neck fullness, tender. So the sign will feel diffuse enlargement, ada bruit. For the cardiorespiratory, patient will complain of palpitation, dyspnea and chest pain. Also ECG show AF or sinus tachycardia. Sometimes hyperdynamic precordium and congestive heart failure. So by dermatological, hair loss, pretibial myxedema, warm or moist skin, palmar erythema. So ophthalmological, so we can patient will sometimes complain of diplopia, eye irritation. By sign, we can see of exophthalmos, ophthalmoplegia, conjunctival injection. Okay, so that's all for sign and symptom, and also how to diagnose. So we go to the aiming of treatment lah. So the aiming of treatment for the thyroid storm, we aim for inhibiting synthesis and release of thyroid hormone. The second one, to inhibit the peripheral action of thyroid hormone. The third one is to reversing the systemic decomposition. Fourth one is treating the precipitating event and addressing definitive therapy lah for underlying causes tu lah. Okay. So how to inhibit synthesis? We started with high dose PTU, profithioracil, or metimazole lah, MMI. So the recommended dose for profithioracil is loading about 500 to 1000 milligram, and then 250 milligram for hourly. For metimazole, 60 to 80 mg per day, single dose or divided into 2 equal dose. So such a last dose of the anti-thyroid drug ni, we should monitor the adverse effect lah, liver dysfunction, rashes and granulocytosis. Okay. So in condition where the absorption of oral profithioracil or MMI is compromised, we can give rectal anti-thyroid drug lah. To prepare PTU, so we can prepare either enema or suppository. For enema, 400 milligram in 90 ml of serai water. For suppository, methylene glycol base 200 milligram of PTU in each. Okay. Then we want to inhibit the peripheral action of thyroid hormone.
Okay, we go back to just now regarding the PTU. PTU normally is the first drug that you want to give lah. The moment you already diagnose patient having thyroid storm, okay, thyrotoxicosis. So for the PTU, normally we will give oral lah. Okay, rarely lah. I have not seen yet given
Rectally.
route, corrector route, because it's quite messy and it's difficult to give. Normally kita bagi oral. Even patient yang intubated, ventilated, semua kita still
Oral.
give oral lah. Oral is much easier to prepare. Ni so far sini kita tak ada bagi lagi yang through the corrector route. Okay. But it's not wrong lah, tapi so far we have not done it yet lah.
Good to know lah. Jangan insist. Nak practice.
Okay, can continue.
Okay. Then peripheral action of the thyroid hormone in thyroid storm. So we give beta adrenergic receptor antagonist to control the heart rate. We give beta blocker, which the ability to inhibit the type 1 diodenase such as propanolol. So portion to be excised with patient in decompensated heart. The second one, we can give selective beta 1 blocker such as bisoprolol, landiolol, esmolol infusion, which more benefit lah in patient with cardiovascular and cardiac compromise lah. So if there are contraindication to beta blocker such as patient with bronchial asthma, COPD, and cardio-selective calcium channel blocker can be used lah, such as dialtazem or intravenous esmolol lah, which have shorter half-life and easier to reversibility lah. In case in use in ICU setting to control heart rate. Okay.
So if in our ED kita bagi apa? What the choice of beta blocker in ED?
Bisoprolol ataupun propanolol lah.
Normally you can give propanolol lah. We can either give IV or oral lah. If IV not available, you can give oral. Propanolol. Tapi kena minta pharmacy lah. You have to endorse the drug. It's not readily available here. Okay, can continue.
Okay. Then in patient with AF, cardioversion should be considered lah after ruling out cardiac thrombosis if hemodynamically are impaired lah. So using the chart S2 score lah. So the mnemonic is congestive heart failure, hypertension, age more than 75 years old, FDM, and also stroke double the weight, score more than 2 So yang require anticoagulation tadi
ni jangan salah faham pula. Ni dalam konteks thyrotoxicosis atau thyroid storm. Janganlah masa patient kau duduk tengah treat for thyrotoxicosis atau thyroid storm kau duduk kira chart VASCO ni. Sometimes the AF tu, once kau dah treat the thyrotoxicosis tu, the AF is a manifestation of the thyroid problem. So it's not a primary AF problem. AF dalam konteks thyrotoxicosis or thyroid storm ni is a manifestation of the thyrotoxicosis. So kau kena treat the thyrotoxicosis dulu. Chart VASCO ni is really once patient dah stable dan still ada AF. Then baru kau kira lah. So dia a little bit out of context lah dalam kau punya lecture ni. So tak perlu pening pasal chart VASCO untuk thyrotoxicosis lah.
Faham. Okay, continue. So to inhibit both thyroid hormone synthesis and peripheral conversion of T4 to T and T3 lah. So we use corticosteroid prophylaxis for relative adrenal insufficiency caused by hypermetabolic state in thyroid storm. High dose of glucocorticosteroid lah. We use IV hydrocortisone 100 mg 6 hourly or dexamethasone 2 mg 6 hourly lah. Okay. Yang ni case of kita nak as a prophylaxis lah. So in relative ada adrenal insufficiency lah, is suspected lah. Okay. Then inhibition of iodide oxidation and organification, and to inhibit the release of thyroid hormone, sometimes we use inorganic iodide lah, glucose iodine, or SSKI, saturated solution of potassium iodide, to rapidly decrease T4 level. Inorganic iodide can reduce thyroid hormone faster than steroid or anti-thyroid drug. So recommended dose is 5 drop of glucose iodine in 6 hourly, 6.25 mg iodine per drop, or 10 drop of glucose iodine 8 hourly. So other agents we use lithium or cholecystographic agents, which an alternative for patients who cannot tolerate MMI or PTU, and works by inhibiting release thyroid hormone by thyroid gland through unknown mechanism. Recommended of lithium is 300 mg thrice daily. Adverse effect that can be considered is lithium toxicity and nephrogenic diabetes insipidus. Cholestyramine has been used as an option to improve thyrotoxic state in thyroid storm by reducing enterohepatic recycling of thyroid hormone. Recommended dose for cholestyramine is 1 to 4 gram every 6 hourly. So sometimes if failure in standard therapy, we should consider to TPE or total plasma exchange. So how we can say the failure of standard therapy? We consider is a failure when thyroid storm shows no improvement within 24 to 48 hours of standard multimodal therapy. Two type of replacement, either FFP or albumin, to be used in total plasma exchange of thyroid storm . So FFP have been professionally used because it contains thyroid binding globulin (TBG), will better enhance removal of the TBG bound thyroid hormone . What is the role of other supportive therapy? So the supportive therapy ni is the fourth line before the definitive therapy. So if in cardiogeny we give intravenous fluid or fluid resuscitation.
Okay, Syahmi, the supportive therapy you can start concurrently. All the supportive therapy you give together with your definitive therapy. Your PCM, your IV drip, semua you can start concurrently. Okay. And then fluids, all this. Okay.
That's all lah. Then with hyperthermia we give cooling, and also in DKA we support with broad spectrum antibiotic if suggested infection. For CNS or respiratory failure, we give invasive or non-invasive ventilation lah. So definitive therapy is actually to treat the causes, the main causes lah, after patient stabilize lah. Okay, that's all lah for my slide.
Any questions from audience? I think the most important is to recognize that patient is having thyroid storm. You can use your Bush-Watowski score to help you to guide you in making your diagnosis. Okay, then from there you can proceed with your management lah. Okay, Dr. Fairuz nak tambah apa-apa? Anything to add? No? Okay lah. Okay, if got no questions, I think we can end today's CME.
Okay, thank you everyone.
Thank you to the presenter lah.
Rafeek.
Okay, thank you.
Okay, thank you, Doctor.
Okay, thank you.
Thank you everyone for listening.